Have you ever, needed to get up to speed on a really complex medical topic fast? Especially when it involves kids' health. It can feel like you're drowning in jargon, right? Trying to find the key takeaways. Well, today we're doing a deep dive specifically into alterations of hematologic function in children. It's based right on a key chapter in Understanding Pathophysiology. Our mission, really, is to walk you through it, step by step.
Yeah.
The main ideas, how things work, some clinical examples, covering blood disorders in kids. We
Yeah.
want to make it super clear, whether you're a student or just curious, no overwhelm.
Absolutely. And what's really striking about this chapter, I think, is the sheer range of conditions. We go from like the most common nutritional issue right through to complex genetic disorders and even cancers. And they all impact the child's growth and development in, well, really profound ways. So we'll try to connect those dots, the causes, the effects, and, why it actually matters.
Okay, sounds good. So, to keep things organized, we've basically broken this down into three main chunks. First up, red blood cell disorders, erythrocytes. Then, we'll look at coagulation and platelets, the clotting stuff. And finally, neoplastic disorders, that's the childhood blood cancers. Ready to jump in?
Let's do it.
All right, first stop, anemia. Probably the most common blood disorder in children overall. It basically means not enough healthy red blood cells, right? Either not making enough or losing them too fast.
Exactly. And the big one here, the most common type by far, is iron deficiency anemia, or ID.
IDA, right.
Yeah, and it's not just common, it's actually the top nutritional disorder worldwide. We see it peak typically between 6 months and 2 years old. And here's the really critical piece. Iron is absolutely essential for brain development, severe IDA, especially early on. It can cause irreversible cognitive damage.
Wow, irreversible.
Yeah,
That's a big deal. So it's not just about feeling tired.
not at all. It's
Right.
often called a silent thief for that reason.
So what causes it? Why does it happen? And
Right.
what's it actually doing to the blood cells?
Well, the number one cause is usually diet, just not getting enough iron, especially, in babies drinking mostly milk, which has very little iron.
Mm-hmm.
But it can also be problems absorbing iron, maybe chronic diarrhea, or even slow, steady blood loss. Think parasitic infections, or maybe too much cow's milk in young kids causing tiny bleeds in the gut.
Okay.
And what it does to the cells? Well, they become hypomicrocytic. Fancy term, but it just means they're smaller and paler than normal red blood cells, less hemoglobin.
And I gather the symptoms, especially at the start, can be pretty sneaky. Easy to miss.
Very much so. A bit of listlessness, maybe some irritability. Could be anything, right? But as it gets worse, you start seeing more obvious things. Paleness, poor appetite, maybe a faster heart rate. And sometimes you see pica, that weird craving to eat non-food things like dirt or clay.
Right, pica. Okay. And diagnosis is straightforward. Blood tests, diet history.
Pretty much.
Cool.
Standard blood counts, iron levels, ferritin. And treatment usually involves oral iron supplements, often given with vitamin C, actually helps the body absorb it better.
And diet changes too, I assume, like less cow's milk for the little ones.
Definitely. Keeping cow's milk within recommended limits is key for toddlers.
Okay, let's shift gears a bit. Another big red blood cell issue, this one affecting newborns. Hemolytic disease of the fetus and newborn. HDFN. Sounds serious.
It can be, yes. It's what we call an alloimmune disease,
Autoimmune.
meaning the mother's immune system reacts against something foreign, in this case, antigens on the baby's red blood cells. Basically, if mom and baby have incompatible blood types, mom's antibodies can cross the placenta and attack the baby's red cells, causing them to break down or hemolyze.
And there are different types of incompatibility.
Right, ABO incompatibility is actually more common, but usually it's milder.
Brr.
RH incompatibility, while less frequent, is the one that can be really severe.
And RH incompatibility, that's the one where it often gets worse with later pregnancies, right?
That's the classic scenario, yes. Think about the diagram in the book, figure 24.1. Picture this. First pregnancy. An RH negative mom is carrying an RH positive baby. During delivery, maybe some fetal red cells slip into her circulation. Her body sees these Rh positive cells as foreign and makes antibodies against them. Usually no harm done to that baby.
But the next time.
Exactly. The next time she carries an Rh positive baby, her immune system is primed. Those maternal antibodies, specifically the IgG type, which are small enough, cross the placenta. And once they're in the baby's system, they just start destroying fetal red blood cells.
Okay, and the consequences of that destruction, what happens to the baby?
It leads to fetal anemia, sometimes very severe. After birth, the problem shifts. The placenta isn't there anymore to clear out bilirubin, which is a breakdown product of red blood cells. So the baby gets hyperbilirubinemia, very high bilirubin levels. If that gets too high, it can deposit in the brain. That condition is called kernicterus.
Kernicterus.
Yeah, it causes terrible brain damage, cerebral palsy, intellectual disabilities, or even death. And in the most extreme cases in utero, the severe anemia causes massive edema hydrops fetalis, often leading to stillbirth.
That sounds devastating. But there's prevention, right? You mentioned ROGAM.
Yes, thankfully, that's been a huge lifesaver. Giving Rh immune globulin, or ROGAM, to Rh negative mothers prevents them from forming those antibodies in the first place.
Yeah.
It's routine now.
Okay, good. Let's move to another really significant one. Sickle cell disease. This is a genetic disorder, right? Autosomal recessive.
Correct. Autosomal recessive means you need to inherit the faulty gene from both parents to have the disease. And it all comes down to a tiny change, a single amino acid substitution in the hemoglobin molecule.
Yeah.
The protein that carries oxygen in red blood cells.
Uh,
This creates what we call hemoglobin S, or HbS.
Just one tiny change, and that causes all the problems. What does it actually do to the red blood cells?
It's amazing, isn't it? That one change is, well, catastrophic for the cell's function. Under certain conditions like low oxygen dehydration, even changes in pH, this HbS clumps together, polymerizes. And this polymerization forces the normally round, flexible red blood cell into a rigid C shape, or sickle shape. You can really see in the book's figures 24.2 and 24.3. They show electron micrographs. You see normal round cells right next to these elongated, distorted sickle cells. It's dramatic.
And these sickled cells, they cause blockages?
Precisely. They're stiff, they're sticky, they can't squeeze through tiny capillaries like normal cells can. So they pile up, block blood flow. Plus, they don't live as long as normal red cells, maybe only 10, 20 days instead of 120. This leads to chronic hemolytic anemia.
So the blockage is the main problem day to day.
It's a huge part of it. Figure 24.4 illustrates this really well. It's a vicious cycle. Low oxygen causes sickling, sickling causes blockages, blockages reduce oxygen flow even more.
Which causes more sickling.
Exactly. And these blockages, these vascular occlusions, they cause intense pain. We call these episodes vasoclusive crises. They can happen anywhere, and over time, they damage organs, spleen, lungs, kidneys, brain, due to lack of oxygen or infarction.
Are there other types of crises?
Yes, especially in young kids under 5, you can get sequestration crises. That's where a huge amount of blood suddenly pools in the spleen or liver, causing rapid enlargement and severe anemia. It's an emergency.
And symptoms usually start later, after infancy.
Right, usually not before about 6 months. Newborns still have a lot of fetal hemoglobin, HbF, which actually protects against sickling. As HbF levels drop and HbS levels rise, that's when symptoms typically kick in.
It's fascinating, though, that the trait, just having one copy of the gene, actually offers some protection against malaria.
It is fascinating. A real example of a genetic trade-off, especially in regions where malaria is common. That's why the trait is more prevalent there.
And treatment. What can be done?
A lot of it is supportive. Managing pain, staying hydrated, preventing infections. There's a drug called hydroxyurea that helps increase HbF levels, which reduces crises. Transfusions are used, especially to prevent stroke, but they bring their own issues like iron overload, and the only real cure currently is hematopoietic stem cell transplantation.
Okay, let's touch on the thalassemias next. Also genetic, also affecting hemoglobin. How are they different from sickle cell?
Good question. Thalassemias are also autosomal recessive, but here the problem isn't an abnormal hemoglobin structure like HbS. It's a reduced quantity of normal hemoglobin chains. Remember, adult hemoglobin, HbA, has 2 alpha chains and 2 beta chains. In thalassemia, there's a defect in making either the alpha chains, alpha thalassemia, or the beta chains, beta thalassemia.
So you make less of one of the building blocks.
Exactly. And this creates an imbalance. For instance, in beta thalassemia major, where you make very little beta globin, you end up with an excess of alpha chains. These excess chains are unstable. They precipitate inside the red blood cell precursors in the bone marrow and also immature red cells. This damages the cells, leading to their destruction both in the marrow, which we call ineffective erythropoiesis, and in the spleen. Figure 24.7 in the text kind of illustrates this pathogenesis for beta thalassemia major. You see the bottleneck in beta chain production leading to that damaging alpha chain buildup.
And the severity depends on how many genes are affected. There's major and minor.
Right. Minor forms, where you're heterozygous, usually mean mild anemia. Major forms, being homozygous, are much more severe. Beta thalassemia major causes profound anemia, leads to impaired growth, significant strain on the heart, potentially high output heart failure. You also see characteristic bone changes because the marrow expands, trying desperately to make more red cells. This can lead to things like that chipmunk facial appearance.
And alpha thalassemia may...
That one is usually fatal. If all 4 alpha globin genes are deleted, The fetus can't make any functional hemoglobin that releases oxygen effectively. This leads to severe hydrops fetalis and death, often in utero.
So treatment for the major forms, similar to sickle cell.
Largely supportive, yes. Regular blood transfusions are essential to manage the severe anemia. But that leads to iron overload, so chelation therapy to remove excess iron is critical. And again, stem cell transplantation is the only curative option for thalassemia major.
Okay, that covers the major red cell disorders. Let's shift now to the components involved in clotting platelets and coagulation factors. What goes wrong there?
Well, the classic examples here are the hemophilias, hemophilia A and hemophilia B.
Right, inherited bleeding disorders.
Exactly. They are X-linked recessive conditions, meaning the faulty gene is on the X chromosome, so they primarily affect males who inherit the faulty X from their carrier mothers, though about 30% are new mutations.
And what's missing?
In hemophilia A, it's clotting factor 8. In hemophilia B, it's factor 9X. Both are crucial proteins in the sequence of reactions that forms a stable blood clot. Interestingly, because factor 8 and IX work so closely together in that cascade, the symptoms of hemophilia A and B are basically identical. You can't tell them apart clinically. Hemophilia A is the more common one, though.
And the classic symptom we associate with hemophilia.
It's bleeding into joints hemarthrosis. Knees, elbows, ankles are the most common spots. Repeated bleeds can cause chronic joint damage.
But they can bleed elsewhere, too.
Oh, yes. Muscle bleeds, sometimes after minor bumps, bleeding in the mouth, blood in the urine. And the most dangerous are bleeds inside the skull or other internal organs.
Diagnosis involves checking factor levels.
Correct. Blood tests will show a prolonged PTT clotting time, but a normal PT time. Then you measure the specific levels of factor 8 and IX to confirm the type and severity. Treatment now is much better than it used to be. It involves replacing the missing factor, usually with recombinant factors made in the lab, given intravenously.
Okay. Now, what about platelets? What's the common issue there?
The most common disorder of platelet consumption in kids is primary immune thrombocytopenia, or ITP.
Immune thrombocytopenia. So the immune system is attacking platelets.
Precisely. It's an autoimmune thing. Often it seems to be triggered by a recent viral illness. The body mistakenly makes antibodies, usually IgG, that stick to the platelets. These antibody-coated platelets then get recognized as abnormal and are destroyed prematurely, mostly by macrophages in the spleen. The bone marrow tries to compensate, but it just can't keep up, leading to a low platelet count thrombocytopenia.
And how does that present? What would you see in a child with ITP?
Typically, it's a pretty sudden onset. You see bruising, maybe lots of little red dots under the skin, that's the petechial rash. Sometimes larger bruises, called ecchymoses, maybe nosebleeds or bleeding gums. Usually this happens about 1 to 3 weeks after they've had some sort of virus.
But otherwise the child feels okay.
That's the key thing. Usually, yes. Aside from the bleeding signs, the child typically looks and feels well. The big worry, though rare, is intracranial hemorrhage, bleeding in the brain.
How is it treated?
Often, just observation, especially if bleeding isn't severe. The body frequently sorts itself out. If bleeding is significant, treatments like IV edge, intravenous immune globulin, or corticosteroids can be used to boost the platelet count temporarily. But here's the really good news. The prognosis for childhood ITP is excellent. About 75% of kids recover completely within 3 months, many just spontaneously.
That's great to hear. Okay, so we've covered red cells, clotting factors, platelets. Now we move into the really challenging area, neoplastic disorders or blood cancers in children.
Right. And the most common type by far is leukemia.
Leukemia, cancer of the blood-forming tissues.
Exactly. Usually originates in the bone marrow. Instead of producing healthy white blood cells, the marrow churns out abnormal, immature white cells called leukemic cells or blasts. It's the #1 malignancy in children and teens, and most of it, about 75%, is acute lymphoblastic leukemia, or ALL.
ALL. And the other main type
is acute myeloid leukemia, or AML. Chronic leukemias are pretty rare in kids.
So ALL involves lymphoblasts, AML involves myeloid blasts. What's the core problem they cause?
In both cases, these malignant blasts basically take over the bone marrow. They proliferate uncontrollably and crowd out the normal marrow cells responsible for making red cells, healthy white cells, and platelets. You can see this in figure 24.8, which shows these large abnormal monoblasts in AML. They just fill up the space. This leads to bone marrow failure.
And the symptoms directly reflect that failure.
Precisely. Because you're not making enough red cells, you get anemia, so pallor, fatigue. Not enough platelets means easy bruising, petechiae, bleeding. And not enough functional white blood cells means increased risk of infection, so fever is common.
Can these leukemic cells spread outside the marrow?
Yes, that's called extramedullary invasion. They can infiltrate almost any tissue. Common sites are the central nervous system causing headaches, vomiting, and bones and joints, which can cause pain sometimes mistaken for arthritis. Very high blast counts can also cause leukostasis, where the cells kind of sludge up blood vessels, potentially blocking flow to the brain or lungs.
How is leukemia treated?
Combination chemotherapy is the mainstay. Treatment protocols are complex and depend on the type of leukemia and risk factors. For all, the outcomes have improved dramatically. The 5-year survival rate is now around 85%, which is remarkable.
That's fantastic progress. Is AML prognosis similar?
Unfortunately, AML is generally harder to treat. It often requires more intensive chemo, and hematopoietic stem cell transplant is used more frequently, especially for relapse disease or high-risk cases.
Okay. Beyond leukemia, what about lymphomas?
Lymphomas are the other main group of blood cancers in kids. These arise from lymphocytes, but instead of primarily being in the marrow and blood like leukemia, they typically start as solid tumors in lymphoid tissues like lymph nodes, spleen, thymus.
And there are two main categories here, too.
Yes, non-Hodgkin lymphoma, NHL,
Yeah.
and Hodgkin lymphoma, HL.
Let's start with non-Hodgkin lymphoma.
NHL is actually a diverse group of cancers. In children, they tend to be quite aggressive and offer widespread at diagnosis. The most common types are Burkitt lymphoma, lymphoblastic lymphoma, and large cell lymphoma. Burkitt lymphoma, for example, is known for its rapid growth and is often linked to a specific genetic change involving the MYC gene, and frequently also associated with the Epstein-Barr virus, EBV.
So symptoms depend on where the lymphoma starts?
Exactly. If it's in lymph nodes, you'll see swelling neck, armpit, groin. If it's in the chest, maybe trouble breathing or swallowing. Abdominal involvement can cause pain or swelling. Weight loss, fever, night sweats can also occur. Interestingly, African Burkitt lymphoma often involves the jawbone.
Treatment is mainly chemotherapy.
Yes, intensive combination chemotherapy is the standard. And despite being aggressive, many childhood NHLs, particularly Burkitt, respond very well to treatment with high cure rates.
Okay, now Hodgkin lymphoma, how is that different?
Hodgkin lymphoma behaves a bit differently. It typically arises in a single lymph node or chain of nodes and tends to spread in a more orderly, predictable fashion to adjacent nodes. And the absolute defining characteristic of Hodgkin lymphoma is the presence of specific malignant cells called Reed-Sternberg cells.
Reed-Sternberg cells, what do they look like?
They're very distinctive under the microscope. Figure 24.9 shows one beautifully. They are very large cells, often with multiple nuclei or a lobe nucleus, and really prominent nucleoli that can look like owl's eyes. They're surrounded by various inflammatory cells. These Reed-Sternberg cells are abnormal B lymphocytes, and their survival seems linked to signaling pathways like NFP, which might sometimes be activated by EBV infection.
And the typical presentation for Hodgkin lymphoma in kids?
Most often, it's painless swelling of lymph nodes, usually in the neck or above the collarbone. Figure 24.0 diagrams and common sites. Sometimes there are systemic symptoms like fever, night sweats, weight loss called B symptoms. If there's a large mass in the chest, mediastinum, it can press on the airway, causing cough or shortness of breath.
Treatment for Hodgkin, chemo, and radiation?
Traditionally, yes. But because survivors of childhood Hodgkin face long-term risks, like secondary cancers from the treatment, modern protocols focus on reducing toxicity. This often means less intensive chemotherapy and using radiation more selectively or at lower doses, sometimes replaced by more chemo. Targeted therapies are also becoming more important.
Wow. Okay, we have really covered a lot of ground here. An incredible overview of pediatric hematology from that chapter. We started with those red blood cell disorders, IDA, HDFN, the complexities of sickle cell, the thalassemias. Then we hit coagulation issues like the hemophilias and the immune attack on platelets and ITP. And finally, the neoplastic disorders, the leukemias, ALL and AML, and the lymphomas, non-Hodgkin and Hodgkin. It's a huge spectrum.
It really is.
Yeah.
And understanding the underlying mechanisms of pathophysiology is just so crucial for grasping why these diseases manifest the way they do and how treatments work. It really makes you think,
Yeah.
as our understanding of the genetics, the cellular pathways keeps getting deeper and deeper, how will this continue to revolutionize how we diagnose and treat these conditions, especially offering, more targeted and hopefully less toxic options for children?
That's a great point. It's a journey that highlights both the vulnerability and the amazing resilience of children's bodies, and also the incredible pace of medical science. There's always more to learn, always new hope developing. Definitely keep that curiosity alive.
Well said. Thank you for joining us on this deep dive.
Yes, thank you so much for tuning in.